My pleasure to introduce Dr. Brian Skian, who will introduce today's speaker. Dr. Skian is Director of Child and Adolescent Psychiatry and Director of College Mental Health.
Thank you very much, Dr. Rothschild. Today, it is my pleasure to introduce Dr. Sarah Palmer, one of our Chief Fellows in the Child and Adolescent Psychiatry program. Dr. Palmer graduated from, completed her undergraduate at Cornell University before attending UMass Chan Medical School, where she graduated before joining our integrated adult and child residency program. Before medical school, she actually spent some time working as a legal assistant and as a quality improvement project coordinator at Steward Healthcare. Since she has been in school, she has remained active academically throughout school and residency training, including serving as a member of the Disaster and Trauma Issues Committee at ACAP, and has been recognized for some of her research projects, including with the Paul Brascoli Award for her collaboration with Dr. Cochran. Her current work explores connections between public policy and mental health outcomes in families and children, and has a longstanding interest in community mental health, neurodevelopment, and policy for mental health outcomes. Because I know her talk is dense and filled with really good information, I'm going to now pass it over to Dr. Palmer. Welcome.
Thank you very much. Hi, everybody. So this is my topic, policy and family mental health in post-Roe America. I have no disclosures to report. We have a lot to cover, and I will preface this by saying I will not go into as much depth as I would like in order to make sure that we get out on time, but to give you a brief outline, we will start with the first half of our talk being about the history of abortion discourse. I will kind of jump around between legal, medical, and political pieces of this, and just to prepare you. In the second half of our talk, we'll talk about the epidemiological inquiry of abortion, which really started around the 2000s. And then I will briefly touch on current questions that I'm working on in my research with my mentorship. So the first thing that I realized when I started researching for this talk was that the 60s were a really wild time. And by that, I mean the 1860s. This is Dr. Horatio Storer, and to give you some context, he was practicing as an OBGYN in 1860, and abortion law before then was really not much litigated or discussed. The idea of bodily integrity, or the idea that people have the right to determine what they do with their bodies, was something that was discussed in the Magna Carta in 1215 in medieval law, where nobles said to the king, you know what, just because you're king doesn't mean you can tell me what to do with my body. And that really did trickle down into the US Constitution and continued for a century before the people started to discuss this publicly. Now, Horatio Storer was born in Boston. He went to Boston Latin, Harvard College, Harvard Medical School, and he was a really influential leader in the American Medical Association. He won a prize for his essay informing women about the moral and physical problems of induced abortion. And he founded the Gynecological Society of Boston, which was the first medical society devoted to gynecology, and published the first gynecology academic journal, the Journal of the Gynecological Society of Boston. In a letter that was sent to the governors of every state in the United States in 1860 from the American Medical Association, he wrote, "The evil to society of this crime," meaning abortion, "is evident in the fact that its instances in this country are now to be counted by the hundreds and thousands. In reality, there is little difference between the immorality by which a man forsakes his home for the occasional visit to a house of prostitution, that he may preserve his wife from the chance of pregnancy, and the immorality by which that wife brings herself willfully to destroy the living fruit of her womb. The child is alive from the moment of conception." So this brought abortion to the public eye, and medical doctors at that time were publicly against abortion. So this is the book that Dr. Storer wrote that was disseminated to women throughout the United States. It was the prize essay to which the American Medical Association awarded the gold medal. And the debates, just to give some historical context to when these debates were happening, emancipation had taken place in 1863. There were influxes of immigrants from Northern and Western Europe. The West was being hotly, there was a lot of violence and colonialism in the West where people of the First Nations were still living. So this was happening in the context of a lot of changes in the demographics of the country. He wrote in his book, all of the fruitfulness of the present generation tasked to its utmost, meaning fertility, can hardly fill the gaps in our population that have been of late been made by disease and the sword, while the great territories of the far west, just opening to civilization, meaning people of the First Nations, and the fertile savannas of the South, now disenthralled and first made habitable by freemen or freed slaves, offer homes for countless millions yet unborn. Shall they be filled by our own children or by those of aliens? This is the question that our own women must answer. Upon their loins depend the future destiny of the nation. Now, this language may sound kind of familiar, and these are kinds of messages that we still get today about a fear of replacement in the United States, of the true American versus the immigrant, versus the Black person versus the not white person. And it's termed the Great Replacement Theory. And we hear this all the time through political platforms, misinformation campaigns, demonstrations, mainstream media. And it does end up having huge impacts on our democracy and the current state of our nation. So pre-Roe abortion law, medicine and society. So this gentleman is Anthony Comstock. He was an anti-vice activist and the US Postal Inspector. And what he did as the secretary for the New York Society for the Suppression of Vice was he censored mail. He was very much against obscene literature and any information about abortion, contraception, gambling, prostitution, or patent or over-the-counter medicines. And his laws, the Comstock laws, prevented a lot of information being shared with the population of the United States and prevailed until the mid-20th century. I think that the last Comstock laws were removed in the 1960s. So this person was very influential and played a big role in how information was disseminated. And just to give you a sense of how powerful these laws were, there were medical students who could not receive anatomy textbooks in the mail. And there were people who were sent to jail for sharing information by mail. And people like Margaret Sanger, who was the founder of Planned Parenthood Federation for America, she was charged with, under Comstock law, and I'll just continue. But so she was charged with, under the Comstock law. Oh, there, came back. Okay. And she went to Europe for some time to escape the penalties for her actions of sharing information about abortion. So by 1900, the activism of the medical community, as well as many people who were now really disturbed by abortion, it had been effective. Abortion had become a felony in every state. Margaret Sanger was an activist. She was really interested in providing birth control for women and sought organization to help this become accessible to every woman. And even though it was illegal, by the 1930s, still licensed physicians performed abortions, about 800,000 per year. Despite being illegal, the clinics would run openly and juries often refused to convict abortion providers. There was widespread acceptance of the practice. This is a slide that I made for the local audience, just for anyone who might not be aware. This is Dr. Gregory Pincus, and this is Min-Shui Shang, who is a reproductive biologist who emigrated from China. And Margaret Sanger had a friendship with Dr. Gregory Pincus, who was of the Worcester Foundation for Experimental Biology, which is located on Maple Avenue in Shrewsbury in one of the current UMass office buildings. So if you ever want to go visit where they discovered the birth control pill and where it was FDA approved in 1960, it's about 10 minutes away. So we're going to talk about kind of the tale of two abortions. And what I want to talk about is how media started to play into the movement for abortion rights. So in the 1960s, these two women received heavy media coverage, and this impacted public opinion on women's rights to bodily integrity. The woman on the left is Sherry Chesson. She was born in 1932, and she was Miss Sherry, which was a Phoenix Children's TV personality on the show called Romper Room. She sought an abortion after discovering that the thalidomide she had been taking during her pregnancy caused serious fetal deformities. And her physician recommended a therapeutic abortion, which was the only type admitted in Arizona at the time. She wanted to publicize the danger of thalidomide as she was a public figure. And she contacted the Arizona Republic, which published the story, but did not honor her request for anonymity. When the hospital found out about this, they were fearful of being prosecuted, and they canceled her procedure. Her physician then sought a court order for the abortion, and at that point, she and her husband became public figures, required the FBI to protect her from death threats. She lost her job, and ultimately the case was dismissed by the judge, who found that he did not have authority to make a decision in this matter. She then went to the Royal Swedish Medical Board, and they granted her request to safeguard her mental health, and the operation was performed the following day. On the right, it's a different story. This is Jerry Santoro. She was one of 15 children born to Ukrainian American farmers in Connecticut. She grew up and got married at the age of 18. She had 2 daughters with her husband, who was abusive. She left her husband due to domestic abuse and moved back to her childhood home, took a job in a school. She met a man there and started having an affair with him, and she became pregnant. When her husband announced that he was coming back to see his daughters, she feared for her life. She thought that he would kill her when he discovered she was pregnant. And at 28 weeks, she and her boyfriend checked into a motel, and she attempted to self-induce an abortion. She hemorrhaged, she passed away. And the police photo of her corpse became a symbol of the pro-choice movement, much to the dismay and against the wishes of her family. So these women were famous in the 1960s and painted a picture of how lack of access to abortion impacted women's lives. And following Jerry Santoro's death, women's rights activist groups developed their own skills to provide abortion. Things like Jane, which was a Chicago floating abortion clinic. And then they started to advocate for policies to change. In 1967, Colorado decriminalized abortion in cases of rape, incest, permanent physical disability. In 1970, Hawaii became the first state to legalize abortion on the request of the woman. New York repealed its 1830 law and allowed abortions up to 24th week of pregnancy. Similar policies passed in Alaska and Washington. And then Washington had a referendum on legalizing early pregnancy abortion, and it became the first state to legalize abortion through a vote of the people. In 1971, a Supreme Court ruling, U.S. versus Vich, upheld a law allowing abortion to protect the life or health of the woman, deeming that health meant both psychological and physical well-being. So by 1972, 4 states, these dark magenta states, had repealed their anti-abortion laws, and 13 states, these lighter pink ones, had reformed their anti-abortion laws. And then in 1973, Roe v. Wade was passed, and in the decision penned by Justice Harry Blackmun, deemed that the due process clause of the 14th Amendment to the US Constitution provides a fundamental right to privacy that protects a pregnant woman's liberty to abort her fetus. This right is not absolute. The government also has interest in protecting the women's health and protecting prenatal life. Texas's statutes, which were under debate in this proceeding, made it a crime to have an abortion, and which violated the woman's rights to privacy. In other words, her right to make decisions for herself without government interference. So the map went from something like this to this. So we now had a fundamental right to have abortions. And this was immediately contested in multiple states. So it did not stay like this for long. Skipping forward to 1987, by this time, abortion had become part of political platforms, and the right to life movement had a lot of political sway. Ronald Reagan made a promise to this group to work towards a right to life amendment, which would define a fetus as having the same legal protections as any human life. And he said, "I will not rest until a human life amendment becomes a part of our Constitution." However, he also says that making accurate data on maternal morbidity available to women before an abortion is performed is an essential element of informed consent. I want to highlight that we haven't really heard from a medical doctor in like a really major public way about evidence since the 1800s. At this point, a lot has happened policy-wise without much information or science or evidence on public health impact at this point. So the Surgeon General at the time was General C. Everett Koop. He was a renowned pediatric surgeon, and he publicly opposed abortion. However, he was earnest in his attempt to find evidence. He spent 1.5 years, reviewed more than 250 studies pertaining to psychological impact of abortion. He interviewed women who'd had abortions and dozens of medical, social, philosophical groups on both sides of the debate. Koop called for more and better research. He said, "I regret, Mr. President, that in spite of a diligent review on the part of many in the public health service and in the private sector, the scientific studies do not provide conclusive data about the health effects of abortion on women." He called for a 5-year perspective study. He wanted to analyze all of the many outcomes of sex and reproduction, including psychological and physical effects of trying but failing to conceive, having planned and unplanned, wanted and unwanted pregnancies, and delivering, miscarrying, or aborting pregnancy. So rather than having evidence that was called for, we had further legal contests. So I've really watered this down and tried to summarize this as briefly as possible, but I want to just outline some of these major decisions for you. In 1992, Planned Parenthood of Southeastern Pennsylvania v. Casey outlawed limitations to access to abortion if they placed a, quote, undue burden on the woman seeking an abortion before the gestational age of viability. Then in 2007, in Gonzalez versus Carhart, they upheld a 2003 federal, quote, partial birth abortion ban act, which made illegal the rarely used abortion procedure known as intact dilation and evacuation. Now, I want to call attention to the fact that in the medical terms, there's no such thing as a partial birth abortion. This meant that when abortions are performed, fetuses are required to be dismembered now, prior to being removed, rather than the intact dilation and evacuation that was rarely performed before. So just from an infection risk standpoint, this would lead to more instrumentation during the procedure and is not medically indicated. In 2016, Whole Women's Health versus Hellerstedt, the court invoked Casey to strike down 2 provisions of a Texas law, which would have required abortion clinics to meet the standards of an ambulatory surgical center and abortion doctors to have admitting privileges at a nearby hospital. 2020, we saw another case that was very similar that related to Louisiana. And then in 2021, 2 major things happened. In May, the Supreme Court agreed to review in its October term a lower court's decision to strike down a Mississippi state law, which had been adapted in 2018 that banned most abortions after the 15th week of pregnancy. Now, lawmakers knew that this was plainly unconstitutional under Roe v. Wade and Casey. However, the Mississippi lawmakers passed the measure in the hope that an inevitable legal challenge would eventually make its way to the Supreme Court, where a conservative majority of justices at that time would overturn or drastically reduce the scope of those decisions.
Keep going, it's still going.
Okay. So in May 2021 also, SB 8 was passed in Texas and adopted into law. And what SB 8 did, which was very unusual, not only did it ban almost all abortions beyond the time at which fetal cardiac activity could be detected, which was around the 6th week of pregnancy, the law shifted responsibility from enforcing the ban from state officials, which would have been federal law, to civilians, which put it into the civil law space. So it was no longer protected under Roe v. Wade or the Supreme Court. It became a civil lawsuit where you could sue someone for aiding or abetting the performance of an abortion. Plaintiffs, if successful, would win $10,000 plus coverage of their legal fees. If you were able to successfully defend yourself against such a lawsuit, no one would help you with your legal fees, but you would escape the need to pay the $10,000. This summary is just a tiny fraction of the abortion legislation that has occurred since Roe v. Wade and since Reagan's call for evidence. Studies on the public health impact and implications of these policies, however, had not really gained traction until the last 20 years or so. So this demonstrates that significant policy decisions have taken place for decades to 100 years without a body of evidence to support these decisions. So in 2020, the New York Times published data from the 2019 CDC in an article that talks about who gets an abortion. And it talks about the statistics about the typical patient who gets an abortion. So I found this to be very helpful in changing my lens about how I view abortion. So 60% of the people who seek an abortion already have children. 49% live below the poverty level. 46% were never married or single. And I've included some stock photos here of young mothers and children to kind of start to humanize this conversation a little bit and to change the frame from, this does matter as a women's health topic, but it is also a family and child health topic as well, because the event of having a child is huge. The impact it has on a family is just, there is an absolute huge importance on this event, and it impacts all members of that family, especially children and mothers. In the midst of all of this debate, we have seen that abortions have declined over time, and this was published in 2020. And most people think that this has been due to increased contraceptive use over the last couple decades, and that would indicate that primary prevention is working. This map was included in the New York Times article, which kind of shows the number of abortions per 1,000 women throughout the different states. But the finer detail here is that the declines in the abortion rate were larger in states where widespread abortion access was available. And those that had added restrictions did not see the same declines. So the assumption that we're kind of making is that that having increased access and accepting of women's health would actually reduce the abortion rate. In 2022, Dobbs v. Jackson Women's Health Organization went through to the Supreme Court, and as foreshadowed by the decisions in 2021 that I already reviewed, they repealed Roe v. Wade and Casey. They overruled those decisions, and they put the decision about women's access to abortion to the states and said this is not something that's protected under the Constitution of the United States of America. States need to figure this out. So I want to share a little snippet of the debate. Now, this is from 2012, but it is still relevant today. And it'll be a segue into our discussion about the epidemiological study of abortion and its impact on mental health. This is from a Fault Lines episode where you'll hear Nina Turner, who's an Ohio State representative at the time. She is pro-choice. And there's a counterpoint from Jim Bucci of Ohio State, who is the Ohio State representative, who is anti-abortion.
By the governor.
One of the reasons, in my opinion, that these abortion bills are so insidious, so dangerous, is because it chips away at the notion of personal liberty, your right. And what can be more fundamental to your personal liberty than being able to control your own body?
What do you think makes a woman want to have an abortion?
Well, there's probably a lot of, I'm not a woman, so I'm thinking now, if I'm a woman, why would I want to, yeah. Some of it has to do with economics. A lot of it has to do with economics. I don't know, it's a question I've never even thought about.
Prior.
Okay, let's digest that.
By the governor.
We won't watch it again. Okay, so there's a clear need for evidence in a place where there is like a lack of empathy or ability to imagine really what other people are going through. So it kind of pains me to say that we needed to do research to show why people want abortions. So this is Diana Green Foster. She's a researcher out of UCLA, and she originated the Turnaway study. Now, the Turnaway study is a natural experiment, which basically assumes randomness based on access to a service. So the idea was that if women present to an abortion clinic and some are able to get an abortion and some are turned away, we assume that they've had the same exposure, because the group that's been turned away may have missed their gestational limit by a couple days. So the assumption is that these two are pretty much have equal exposures. The ones who get the abortion are selected at random, and now we have a natural experiment if we can compare those two groups to each other. So between 2008 and 2010, Diana Green Foster's team recruited more than 1,000 pregnant women from the waiting rooms of 30 abortion facilities in 21 states. For every woman denied an abortion due to gestational limit, 2 women who received an abortion just under the gestational limit were recruited, as well as 1 who received an abortion in the first trimester. Of the women who were turned away, 70% carried the pregnancy to term. 30% of those women were able to receive an abortion elsewhere. They've investigated this data set in many different ways. I'm going to focus on the mental health impacts as it's specific to this talk. So one of the really important findings is that they asked women to write freehand what made them want to have an abortion. They didn't give them a list or multiple choice. They felt like that would have biased the data. So women just wrote in, and then they entered all of the data, and then they looked through the data and found the trends. And they found that 40% felt not financially prepared, 36% not the right time, 31% the partner wasn't the right person to raise a baby with, it just wouldn't be right. 29%, they need to focus on the kids they already have. I wouldn't have the resources to do this. 20%, it would interfere with my future. I have plans and I wouldn't be able to have those plans be actualized if I have to be a mother to another baby or to a baby right now. 19% felt not emotionally or mentally prepared. 12% felt like they weren't at a place where they could do it for a health reason. And then 7%, 5%, 4% felt not independent, felt influenced not to have a baby at that time, or just didn't want to have a baby. That was the most rare reason that was reported. So what I think about when I see these reasons as a child and adolescent psychiatrist, I think about the life stage that these women must have been at this point, that they are trying to really become independent themselves. And they view that this event would hinder them from moving and accomplishing the life stages that they would be working on at that time. So the data from the Turnaway study was also used to look at mental health outcomes after abortion, and compared the women who had their abortions near the limit or in their first trimester, and then the ones who were turned away and then later gave birth to their babies, and ones that were turned away and then did not give birth and had an abortion elsewhere. One of the arguments against abortion was that it led to depression or suicidality, anxiety among women who did have abortion, that they would later come to regret it. And the researchers found that of the 956 women in the study, at 1 week after seeking an abortion, compared to the near limit group, women who were denied an abortion reported more anxiety, lower self-esteem, and lower life satisfaction. But over the course of 5 years, the effect of this became less, and it sort of evened out statistically, even though we see like there's a little bit of an uptick here based on the graph and the people who were turned away and then later gave birth. It wasn't found to be statistically significant. So there is also a concern for the existing children. As we talked about earlier, the majority of women who sought abortions had children already and were already mothers. And the Turnaway group did investigate the impact of having or not having another baby after seeking an abortion for the mother, how it would impact the children of that, the living children of that mother. So the researchers interviewed the mothers regarding the health and development of their living children via telephone 1 week after seeking an abortion, and then again semi-annually for 5 years, comparing the children of women who were denied abortion versus those who received an abortion using mixed effects regression models, and tested the differences in outcomes. From 6 months to 4.5 years after mothers sought abortions, existing children of women denied an abortion had lower mean child development scores. Existing children in the Turnaway group had a mean child development score 4 percentage points lower than that of the existing children of women in the abortion group. Self-help was the only one of the 6 individual child development domains that was significantly different by analytic group and adjusted models. The existing children of women in the Turnaway group were less likely to achieve self-help milestones compared to existing children of women in the abortion group, 59% versus 93%. The children of women in the Turnaway group were also more likely to live below the federal poverty level, 72% versus 55%. There was no significant difference in child health or time spent with the caregiver other than the mother. Existing children of women in the Turnaway group had more than 3 times greater odds of living in a household that received assistance from WIC or TANF, and they were more likely for their mother to report not having enough money to pay for transportation, food, and basic household expenses. One of the women who participated in the Turnaway study shared this insight. In the beginning, I was doing good. I had my job and I had my kids and everything, but the reason why I thought I should have an abortion was for the simple fact that all of a sudden everything came down. I lost my job, my bills started to accumulate, so I couldn't do it. I already had 4. How was I supposed to do it with another one without a steady job? The folks at the Turnaway study also looked at the children that resulted from an unwanted pregnancy. So they looked at the women who sought an abortion, was turned away, and had that child. And they compared those children to the subsequent children of women who did not have an abortion, who did have an abortion, sorry. So subsequent children here are the children who were born after a woman sought an abortion, and the index children are the children of the pregnancy where the woman sought an abortion. So you'll see here that we have an odds ratio with 1 basically meaning that there was no difference between the groups. The whiskers on these boxes kind of indicate statistical significance. So if there's overlap, there's kind of less statistical significance. And then if you see something here where there's pretty much no overlap, you could say that that's pretty statistically significant. But there are trends that I think that we can glean from this data. There's a shorter birth interval, which has impact on mother and child physical health. There is poor maternal bonding in the index child. We see here under the child health outcomes, there's a lot of noise in the data with the longer whiskers, but you could see that current physical disabilities, there's a slight trend towards that being more likely in the index child, and for any breastfeeding to be slightly more likely in the subsequent child. The outcome for the subsequent child, for the mother to have a male partner in the household, is much more likely for the subsequent child, and the mother is more likely to live with adult family members for an index child. And they're also more likely to live below the federal poverty level and not have enough money for basic necessities. So going back to my family here, for the index child, this baby, say poor maternal bonding compared to subsequent children, lower incomes relative to the federal poverty level, and more likely to live in households without enough money to pay for living expenses. So moving on from the Turnaway study, I also looked at this more recent study published in JAMA Psychiatry, which looked at the association between state level access to reproductive care and suicide rates among women of reproductive age in the United States. This was a longitudinal ecologic study with a difference in differences analysis, which I will explain soon, which assessed whether an annual changes in the enforcement of state level restrictions to reproductive care were related to annual state level suicide rates versus the rates of death due to motor vehicle crashes. The duration of follow-up varied between different states. It ranged from 4 to 40 years and was contingent on the first year that restrictions were implemented. The models controlled for year and state, as well as fixed effects and other relevant demographic and economic factors. Analyses were conducted between December 2021 and January 2022. So this study was led by Dr. Jonathan Zandberg. He's a PhD in finance and a lecturer at Wharton School at UPenn. His research focuses on gender income equality and the impact of policy changes on access to income. And he and Rand Barzilay, who's a child and adolescent psychiatrist at CHOP, they share a friendship, and they got together to create this paper. Dr. Barzilay's focus, his research focuses on suicide risk and the impact of environmental adversity. So together with their research associates, Alina Visoki and Rebecca Waller, they produced this recent study, which looked at the association between state adaptation of trap laws specifically and suicide rates among women of reproductive age. So I just mentioned trap laws, and what are these? These are targeted regulation of abortion providers, or trap laws. There are many different laws out there. The first one was dated in 1973, which was when Roe v. Wade was passed. So they've been around for a really, really long time. And the three that were mapped in the study had been used in previous studies to look at this type of index. They looked at ambulatory surgical center laws, which would require abortion clinics to meet the same standards of ambulatory surgical centers at great cost to the clinic, with equipment that would often be totally unnecessary to perform an abortion. Admitting privileges to a hospital. I did not know this, but in order to have admitting privileges, you need to actually admit patients to hospitals. And because abortions are so safe, this would rarely happen. So this is a very difficult thing for an abortion provider to do, as well as transfer agreements. So this would be like an agreement between the abortion clinic to say like, okay, if we ever need you, we have a transfer agreement, we're going to be able to transfer a patient to you. And that's kind of also just you could always dial 911, get an ambulance. You know, this is kind of a thing that is not real or necessary. It's real, but frustrating. So they mapped out where the targeted regulation of abortion providers laws were most adapted. So you see the blue states are 0. These beige guys are 1. The white ones are 2, and 3 is the orange. You could see that there's kind of a spread throughout the United States, with most still being at 0. Their design used a difference in difference study, which is a quasi-experimental design. So it makes use of longitudinal data and treatment and control groups. So you'd say that this red line is the treatment group where you'd expect to see an impact from the change. And the green line is the control group where you would not expect to see an impact from the change. And so in this really cleaned up example, you could see that at some point here, this changed and this didn't. And we think it's probably because of this change. And it's typically used to estimate the effect for a specific intervention or treatment to be like the passage of a law, enactment of a policy, or a large-scale program. So the authors for this paper used the motor vehicle crashes as their control. As you can see on the right here, we've split it into the blue, which is women aged 20 to 34, which is their term for reproductive age women. And this red line here is motor vehicle accidents for women aged 45 to 54. And those would be the non-reproductive age women. And then on the left here, you see the same two lines for suicide death rates. So we have our control both through the motor vehicle crashes as well as the women who are not of reproductive age. So even though they don't really have a specific point when a policy was made, as I said, these policies have been changing and in place since the 70s, they were able to also add to their analysis an additional 17 categories, which would impact access to reproductive care. These 17 categories are defined by the National Abortion and Reproductive Rights Action League, or NARAL, and they included economic factors, race and ethnicity, political affiliation. And so you could see that they mapped the trends of Alabama, Texas, New York, and Washington as examples, but they did this for all of the states. And in the weighted index versus unweighted index, it was whether they controlled for the differences between the states in their analysis, which is sort of beyond the scope of this discussion. So ultimately, what they saw here can be demonstrated in this figure. So you see on the y-axis, it's the coefficient, which is the rate of change of the suicide rate. And on the x-axis, you have the years from the trap law enforcement. In the center, we have 0. So that's like the year that the trap law was enforced. And then 1, 2, and beyond years after, and -1, 2 years before. Same thing in this graph, except these are women aged 20 to 34. And on the right, we have women aged 45 to 64. And these are suicide rates among these populations. And so what they saw was that after the trap law was enforced in women aged 20 to 34, we saw an increase in the coefficient of this of the suicide rates, while in women aged 45 to 64, we saw basically a 0 change. So the weighted average annual state level for suicide death rate when no trap laws were enforced was 5.5 per 100,000. And they determined that enforcement of a trap law was associated with a 5.81% higher annual rate of suicide than in pre-enforcement years. So using the information that I found through my work with my friend, colleague, mentor, Dr. Maketa, whose work really focuses on health equity and epidemiology. She and I have been looking at these data and talking about what we can do together. We've decided to start an inquiry to some databases about how these laws and policies changes have impacted the children in these families where abortion laws have been changing and restricting access. And using the examples of the existing literature, we feel like we might be able to start to show how living in a state or in an environment where access to abortion care is limited will have negative impacts on the mental health outcomes for kids. The Turnaway study did a really excellent job of comparing in a natural study but went to 5 years. And so we would be looking at children who are now adults and looking at outcomes from much later, using the Nurses Health Study 2 and the Growing Up Today study. The Nurses Health Study 2 is a database of nurses in the United States who were pregnant and having children. And then the Growing Up Today study is a cohort of those children. So these are linked cohorts. And we hope to look at the exposure of abortion policy climate at the time mom was pregnant and examine the effects of those policy on child and family psychosocial outcomes, including depression symptoms, stress, and family dynamics. So we're reaching the end of this talk, and I wanted to include some helpful information. These slides are, I will gladly send these slides to anyone who is interested. These are just linked images where you can look at where we are now with the policies. When you click on this map, it will bring you to a website where it's interactive, and you could look at, by highlighting each state, you could see what kind of environment the women there are living in. This is a page of links to advocacy sites. So if you want to get involved at all, these are places where you can go. I'd like to highlight IBIS Reproductive Health. That's a local place, and with researchers who might want to partner with anyone who's interested in doing this kind of work. I want to include a thank you. This is Sarah Maketa. I think that she's on the Zoom, so hello. She's not only my mentor and colleague, she's also an old friend. So I'm very, very pleased to be working with her. I'd like to thank all of my mentors here, as well as the ACAB Disaster and Trauma Issues Committee and the Women in ACAB Committee for their help as I've explored this topic, as well as my colleagues for all of their continued support. I had way more sources than this. They are scattered throughout, so I am, but yeah, thank you.
Thank you. Any question?
Sure, that was really, really wonderful. The importance of the turnaround study can't be emphasized enough, because, I think you alluded to this in your talk a bit, but, one of the not infrequent claims about abortion is how detrimental it is to women's health, right? Causes PTSD, depression, substance use, blah, 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 blah. The turnaround study was really, really pivotal, debunking a lot of these claims. So, I applaud you for going into the turnaround study. It's important for children's health, and it's also important for maternal health. I'll also add that in our databases, we have looked at both wanted pregnancy, unwanted pregnancy, and timing versus good timing versus not so good timing, right? As a predictor of adverse perinatal outcomes like preterm birth, but also as predictors of depression and anxiety disorders for example, in our Pink and Blue database, but in other databases we've collected. And the pivotal factor is timing. So, there are people that have like accidental, pregnancies, we call them happy accidents. And even though they weren't anticipating getting pregnant, and, they fall into the, want to get pregnant or versus non want to get pregnant, but it's a timing piece that is so critical to a lot of this.
Thank you. Thank you. I totally agree.
Other questions?
Thanks, Sarah, for reviewing the history. Some of you know this, I think, but in my personal history, I learned something about the transgenerational impact of illegal abortions. My grandmother died a few days after having one on the kitchen, one of those women in the 1920s who provided that service. And as a result, her 6 children all went into different foster care and orphan homes and things like that. They did okay, surprisingly, because they were in good orphan homes and for the most part, good foster care. But they also didn't have a lot of things that otherwise they would have had, like the ability to have education and things like that. And I don't think we actually look at the transgenerational effect of decision like that.
Wow, thank you for sharing that. So it's terrible.
Other questions?
So thank you, Sarah. That was really well-reviewed, large amount of information and kept us engaged because of how critical the topic is. I think there is this huge connection with availability of any resources for raising healthy young families and availability of choice around having another child that is, pretty clear with the maps that you've shown. And with MCPAP for early childhood work that we're doing, just looking at access to evidence-based psychotherapeutic interventions, access to parent management training, and when that's not available, prescriptive practices in children who are under the age of 5. There is a clear geographical difference between different areas of the country that is quite in line with, the maps that you were showing us, where prescribing stimulants and atypical antipsychotics to children is directly correlated to sort of availability of having a choice. And I'm not saying that those are kids who are kids of mothers who, were denied an abortion, but just all of the other safety networks for raising healthy families. It's all in the same discussion. So, having this clip from the conversation about why is a woman choosing to have an abortion and not having any interest in what those reasons might be leads to having those policies on, inavailability of supports to families. And it's just, it's very, very difficult to sort of look at those data.
That'd be really an interesting analysis to do. Yeah.
You have a lot of fans on Zoom. They're just saying great presentation, but there is a question. Is there data on what percentage of women have been involved in anti-abortion legislation?
Oh, wow. I would love to find out. I did not think to look into that angle.
And sort of off
question.
Yeah, not an important study, but I will mention it. Dorothy Sidney did a study with Planned Parenthood of the rates of depression in women, comparing those who had a surgical abortion and those who had mifepristone and whatever the other thing is that goes with it. Because we were interested in, at the time, that mifepristone may have some antidepressant properties. We found no difference in whether they had either procedure.
Interesting.
Just sort of a little footnote.
Yeah, I mean, and I think that's also reflected in the Turnaway study because they separated people who had had abortions close to the gestational limit. So assuming that would be more likely to be a surgical procedure compared to the first trimester abortions, which would be more likely to be mifepristone. And those kind of went together. There wasn't a significant difference in mental health outcomes for the mother, depending on which group they belong to.
All right, well, we don't have any more questions. Thank you very much.
Thank you.